I always feel like you usually enjoy your job best when you match with the types of patients you're dealing with. So I'm a very good coach long-term. I can go long-term with people who are very sick for long periods of time. My son, who's a third-year medical student, he can't do any of that. He is more like a surgeon mentality. It's like, fix it, move on. But I like the relationship part, and I like dealing with, I can walk with people for long periods of time. So this is very short. It probably won't take us but about 30 minutes. What I did do is I brought 3 questions from the diabetes exam, and I want to walk through how to analyze. One of the things that I think is lost in doing the objectives the way you all want them, and I'm happy to do them that for you, but they're much more getting facts down. And the way I'm testing you more is on application, so it's drawing that thing together. So I will say that I think that one of the things we don't do as well, and time limited, and some of it is the ability to have time to develop those things, is to give you exercises where you have to put things together. You all do amazing for the time that you have been doing this, but your ability to put things together sometimes falls apart. Understandable. So some of the things that, and the reason for this, now we're moving into this last quarter of your time in the didactic portion, is that when you get out, nobody will do much focused. I think you'll have to put things more together, but it won't be in a structure, as much a structure as patient care is. But those end of rotation exams, I've looked at them. So more of how I'm writing my test is more patterned towards that. You can blame the second years, because I've asked them what would help, and they said make it harder in the first year. I said they don't want to hear that, but I think what they mean is the test. So if we just stick with knowledge type questions, it will do you no good. So application is important. So I will try to pull more of that going forward. So I brought 3. That was what I have time to pull together, but I think they'll spark some discussion. Okay, so let's start on the first page. So most of you've identified, or the second page, sorry, that this is a chronic pain disorder, really unknown cause. The biggest things that we deal with from a drug standpoint is the pain. How do we manage the pain? How do we manage the sleep? Because their sleep is usually disturbed, and that, you know that. It always makes it hard to deal with anything when you don't sleep well. Depression can be a part of this. They have a high percent. I think somewhere in the handout I've given you that 75% of people will have depression at some point in their lifetime with this, and anxiety is about 60%. So dealing with those, and also doing the fatigue. So fatigue is huge. The student I had told me that was his mother's major problem. It was just the fatigue. And if she could ever get up and get going, he said movement is everything. He said keeping going, exercising, he said that was the key for her over the years that he had watched her. So that's what a lot of our drugs will be geared for. But this disease has lots of underpinning from multiple specialties. And I've listed there somewhere there for you: physical medicine, rehab, mental health specialist would be a few of them. Education is really important, and I included in just a summary of a systematic review of looking at education with fibromyalgia, and here's the things that they found to be effective. Education was effective. It helped people to understand their disease. This is true mostly in medicine for everything. The more people understand, usually the more they will comply with what you want, the better the questions they can ask. Patients that ask questions usually will do better because you will come to a consensus with them. If you can get to that point when you build consensus with patients, then they'll walk out of the door usually happier, and they're more likely to do what you have asked them to do. Types of education, it didn't seem to matter whether they were in small groups, one-on-one, printed information. Some people, that's all they'll want. Some people will like groups. They'll like being around people who have similar problems so that they can learn from them. Number of sessions didn't seem to matter. Some people were in very few, some in a lot. So what seems to matter is that you have some type of education available. If you're in a practice where you have a nurse, it might be very good to have her be one of your point of contact. You can start things, but having somebody they can form a relationship and who can spend a little bit more time on could be very beneficial to you or to them. So in terms of the improvements with education are listed down there is that pain improves, sleep improves, fatigue improves, self-efficacy improves, quality of life improves. 6-minute walk is a validated diagnostic test. We do a lot with older folks is we'll put them out in the hall and we ask them to walk. See if they can go 6 minutes or see how the distance that they can cover in 6 minutes. And the effects were fairly long-lasting, so up to a year, that's pretty good. So keep that in mind as if you are dealing with this population. Educate them about sleep. Here, good sleep hygiene is really important that they form that because it's one of the problems associated with the disease, makes the disease worse, and their ability to deal with things is made worse if they don't have good sleep hygiene. Reassuring them that it is a real illness. You can see that I can sit there and go, you're making this up. No evidence of persistent infection. This has come up because there's more and more diseases now that are associated with fatigue, like Lyme disease. So people hear this and they think, there's got to be something wrong. There's got to be an illness that they haven't figured out, an underlying cause. So reassuring them, if you've gotten to that point where you've ruled out everything, to reassure them, there is nothing else causing this that we know about or can address specifically. Stress, simple relaxation techniques seem to be very helpful. Studies have borne that out. The other is to enroll them in formal stress reduction. Seems to also help. So there's about so 30% of people who present at the time that they are diagnosed have depression. And there's the stats about lifetime prevalence of depression and anxiety. They also need to know that their symptoms will come and go. There is no known cure. There is no known getting over it or remission, but they will go through periods of time where things are better or things may get worse. Majority of people can live long and active lives. It really isn't known to cut life short, except that these folks do have a higher incidence of suicide, which parallels other non-cancer related pain. So not anything different than we see in other diseases that have a lot of pain and fatigue associated with them. Exercise is huge. Getting them to move and to do as much as they can is really important. So aerobic exercise is good. It is a significant impact on pain and their functioning, helps them to sleep better, keeps them more conditioned. The more people sit, the more deconditioned they get. The more deconditioned they get, the less they will move around, and that causes problems for other diseases they may have. Low impact aerobic exercises seem to be better, so walking, riding a bike, swimming are all helpful. Keep your physical therapist in mind if they have limitations. Say they're older and they've got hip or knee pain like osteoarthritis or something that's limiting them, and having a physical therapist who can design a program for them that will keep them active could be very helpful. Pharmacologic therapy. So from the standpoint of drugs, the SNRIs are really the drugs that are the best, or the most studied and have the most data behind it. And it's the older SNRIs, so the tricyclic antidepressants seem to be the drug of choice. Keep in mind pain management. folks. There's also saw a lot of information on cognitive behavioral therapy. If there's a lot of behaviors that are maladaptive that are associated with fibromyalgia, considering getting them into cognitive behavioral therapy seems to be a benefit. Others that I've listed more, so rheumatologists, sometimes RA is more common. So keeping those in the physiatrist, so those are folks who are usually physical medicine and rehab medicine combined. Psychiatrist, so your mental health specialist, maybe a sleep specialist. Psychologist, pain management. And I repeat myself there with those stats. I must have really liked them. Complementary, I've got at the back listing movement type of, what would you call those? Movement therapy, maybe? Meditative movement therapies. So Tai Chi, yoga, some that I can't pronounce in the back, all seem to also help. So when we move to drugs, the predominant target is pain management, and then sleep and depression and the fatigue. So in terms of approach to therapy, it's kind of similar to everything else we talk about. What are the potential benefits? What are the potential side effects? What does it cost the patient? So the SNRIs, the first generation, are fairly cheap. Some of the alternatives or the secondary treatment are more expensive. And then regulatory, whenever I put that, I'm usually talking about insurance. Who is going to tell you what they'll pay for? They're not telling you what you can use. I think we get that really confused. They're telling you what they will pay for. Okay? And patients equate that as insurance won't pay for that. Well, that's exactly right. They won't pay for that, but that doesn't preclude you using it. But it may preclude them using it because of cost. So initial therapy is the old tricyclic amitriptyline. For this drug, we use very low doses. Start with 5 to 10 milligrams. That is just a drop in the bucket. So the doses that we use with fibromyalgia are well below, usually either below or right at the bottom of the usual starting doses for depression. So here we use a very small dose, 5 to 10 milligrams. Usually people do well on about 20 to 30, eventually titrating them up to that. Even at those low doses, they can have the anticholinergic side effects. So sometimes these are harder to use in older patients or people who have cardiac anomalies. We talked about that multiple times with the cardiac arrhythmias that the tricyclics have. Mostly the reason they've been abandoned because of the anticholinergic and cardiac effects. So low doses. Let's see, dizipramine is also in that category. It's also an old tricyclic. It does not have the data behind it that the tricyclics do, or amitriptyline does, but it has less cholinergic effects. So sometimes people will go to it as a means. So keep in mind that we use the old SNRIs for pain management. So can you think of another disease that we have used them where they're the first drug of choice? You wound me. Diabetic peripheral neuropathy. The drug of choice is amitriptyline. Most data is behind it. Usually we give it at night. It's a very sedating drug. I put down 1 to 3 hours before, just to, some people won't fall asleep right away, but it is a very sedating drug, so that helps a lot. These drugs also probably work on substance P, so they work on pain transmission, and that's probably why they are effective, but you've got that anticholinergic side effect, so keep that in mind. At the very bottom is another drug, cyclobenzaprine. That is the old Flexeril. Maybe you've heard of that. It is a skeletal muscle relaxant. Used to give it out like candy, but it's a very sedating drug. Here, the doses that they recommend are very low. 1 to 4 milligrams is just to compare it, for skeletal muscle relaxants, we usually use it in the 10 to 40 milligram range. To get that 1 to 4 milligrams, you have to use the suspension because it comes in a low enough dose or concentration that you could get that. The tablets start at 5 milligrams. So this is a drug that has a tricyclic core, but it doesn't really have any antidepressant activity. Very sedating, like I said. Under adverse reactions, you'll see the anticholinergic. It also has some serotonin effects. So serotonin syndrome could happen if you use it in combination with other serotonin drugs. Under the contraindications, just kind of file it in those antidepressants as not using it with an MAOI inhibitor or within 14 days of an MAOI. Okay, so that's the starting. So you start very, very low. That's the thing to remember with fibromyalgia. You start very low and you titrate to effect or until you get side effects. I think I gave you, it's like, to just show you, it's like 5 milligrams, what I put down, every 2 weeks. It's so low, it's amazing that it's effective. So that's the initial. So moving on to the next, if you have folks who can't tolerate or they don't get effect. Whoops, let me go back. So the main thing with the tricyclics is pain. That's the main thing that you'll treat. You will also be able to treat their sleep problems because of the sedating effects of the drug. When you move on to the second group, this is where fatigue is more the predominant. So unlikely that they will respond as well to a tricyclic. In fact, I would suspect that their fatigue gets worse. Tricyclics have that real hangover effect in the morning. They make you very groggy. It takes a long time for the fog to kind of clear. So it doesn't surprise me that fatigue doesn't respond to this, the older agents as well. So duloxetine is the drug of choice in this second group. Okay? If you remember back to the treatment of peripheral neuropathies, duloxetine is one of the drugs that you can use. It's FDA approved. It's one of the only ones of the antidepressants I can think of that has that approval. So severe fatigue, if they had depression also, you can treat both things with one drug. So the mental fatigue seems to be the most responsive, not general fatigue. In terms of there was a big review of all the studies that have been used using duloxetine for fibromyalgia, and the reduction in pain was at least 50%. And it is sustainable. So that's really good news. So beyond a year, they found that the effects that the patient had were sustained. So that's good. They don't develop a tolerance. The disease never changes. I mean, it doesn't usually get better. It won't. They don't recover. So it stays. And as far as I know, from what I've read, it doesn't become a very progressive disease. It just kind of maintains a certain level with some degrees of gets better and then comes back to baseline. So it's good that these drugs are sustainable. It's important to note that we give this at breakfast or in the morning for the duloxetine. Side effects are common to what we saw with the SNRIs in the past, the nausea, headache, dry mouth has a little bit of anticholinergic effect, not much. Milnacipran or Savella is a alternative. It doesn't have as good a record in terms of efficacy. If you look down there, pain relief is about 30% in about 40% of people. So it's an alternative if they can't take the duloxetine. It is also a morning time drug. So that's the two SNRIs. Venlafaxine has been looked at, limited use, does not seem to be as effective. So these are the only two of the newer generation of the SNRIs. Anticonvulsants. So pregabalin and also gabapentin have been used. Pregabalin or Lyrica seems to be the better of the two. If people are intolerant to amitriptyline, and it's more the sleep that is the disturbance. So we've looked at fatigue with the SNRIs, we've looked at pain with the first generation SNRIs. So here we come to sleep. These drugs are really sedating. Most people will take them at night for sleep. People have trouble taking like Neurontin throughout the day because it does cause a lot of drowsiness. So this is a good one to take at bedtime. It also has a sustainable effect for more than a year, so that's also good. So documented improvements in sleep, fatigue, health-related quality of life, and global well-being. It has a very high side effect profile, though. It's hard for people to tolerate long-term. Dizziness, somnolence, dry mouth, weight gain, peripheral edema, to name the more common. Okay, questions about those? So duloxetine and pregabalin seem to be kind of your best of those categories. And then you may be, duloxetine is still going to be expensive, so will milnacipran and Lyrica. They're all still brand, as far as I know, last I looked. So they'll all be expensive. They're going to differ again on sleep, fatigue, or pain, whichever is the predominant symptom the patient is dealing with. Okay, in terms of prognosis, symptoms tend to continue unchanged, but we do have that somewhat gets a little bit better, comes back to baseline. Most people will be able to do their task of daily living, work full-time or not. Older patients that have fibromyalgia tend to claim more disability, so maybe as folks get older, they cannot deal with those symptoms as well. The poor prognosticators are female gender, low socioeconomic status, being unemployed, and obese, which is exactly what I saw in my clinic. So that may be why my opinion is what it is. Depression, history of drug abuse, catastrophizing. Do you know what catastrophizing is? Anybody? Well, what's the base word?
They make everything seem like a giant catastrophe.
They make everything seem. So there's kind of two things that people do. So one is what happens in the present moment. I failed this test, they're going to kick me out of school. So it's going from a local one thing to making it the worst thing that could happen. Okay? There's also kind of a futuristic, everybody does this. So it's not if you do it and you're thinking, oh my gosh, I got a mental illness. Everybody does this to different degrees. That's the other one is kind of futuristic. So it's taking what's happened today and then rolling it out to the worst possible outcome. I failed this test. I'm going to do terrible when I get on rotations. They're going to hate me. I'm going to do something wrong with my patients. They're going to fail me. And then I'm not going to be able to graduate. I can't pay off my loans. I can't realize my dream. That's catastrophizing. Okay, you're taking one incident and rolling it into the everything bad. Excess somatic concern, you can see where that could be part of this. They are dealing lots with the somatic expression of their disease, the pain, the fatigue, the depression. I told you about the increased risk of suicide. I think I've got all that. Okay, questions about those? You can see where it would need multiple. I think it would be hard to deal with these folks one-on-one. You'll need lots of people's work with them to help them get the best quality of life possible. Okay, so page 6, so what do you do if they don't respond to initial? Well, we can combine therapies. So if you, depending on what the predominant problem is, so you could combine, since you can take the SNRIs in the morning, then you could have them take either a small dose of the pregabalin in the evening or a very small dose of the amitriptyline for sleep. The doses are so low that the overlap in serotonin activity is probably low enough to keep it at a fairly low risk. That third bullet talks about introducing analgesics. So you may be sitting there going, well, it's a pain thing. Why aren't we using non-steroidals or other agents that are more likely to affect the pain? So you can consider Tylenol for breakthrough. You can consider Tramadol, which is a very weak opioid. It's a C4, or the non-steroidals. So let's kind of go down through those. Lack of adherence, which is common with most diseases. Always assess non-adherence. Always expect that that's part of the problem if you're having patients who don't respond or did respond and no longer respond. It could be part of the problem. Also recognizing that pain can come from different sources. So somebody could have this and rheumatoid arthritis. So you've got to treat the pain of rheumatoid arthritis. You have to treat pain that's coming from another source that may be worsening the fibromyalgia, but is not the source of their pain. So Tramadol, let me just say a few words about it. So Tylenol, you know about. Tramadol, again, very weak. It also has a weak opioid. It also has serotonin and norepinephrine activity. So if you ever prescribed like an SSRI or an SNRI in Tramadol, the pharmacy's going to be calling you because they get this major interaction that pops up on their screen. And that's because of that serotonin and norepinephrine overlap of the two drugs. So it is a possible drug to use. Probably the use potential of that drug is very low. Can be used for breakthrough or for short-term treatment of pain. It's really not recommended that you use the non-steroidals or steroids because inflammation is not thought to be a part of this disease or the pain or the source of the pain. So non-steroidals could be used on a limited basis, but they should not be used with a goal of treating fibromyalgia pain. And then steroids have no place in them long-term because of the side effects associated with them. The SSRIs have been used. They may be preferred by the insurance companies because they are cheaper, but they are not as effective. So you may try them if you're forced into it, but they aren't a place to start if you have an option to do otherwise. Complementary and alternative therapies are listed there for you. Again, the movement therapies like Tai Chi, yoga, I do not know how to say Qigong. Anyway, so those seem to be very helpful. Insufficient, you'll see a lot of in the lay literature about using these anthocyanins. So that is what gives foods that real intense color like purple cabbage or blueberries. So those are thought to be very healing drugs, but there is nothing that supports their use in fibromyalgia except healthy eating. Dietary soy, SAMEs, or homeotherapy. There's just no data. If it helps the person, it probably ain't going to hurt them. So there's no reason not to use them from that standpoint. That's all I know about fibromyalgia. Questions? So I'm only going to give Dan 4 questions on the test, and that's why you only have 13 objectives. Okay. Let's go through these questions. And will you not take this part